coronavirus situation, Governor Tim Walz is not participating in today's media call, but we do expect to hear from Health Commissioner Jan Malcolm and others. Let's listen in.
Assistance, please press *0. I would now like to hand the conference over to your speaker today, Mike Schomer. Thank you. Please go ahead, sir.
Thank you, operator. Thank you to everyone on the line for joining us for today's COVID-19 daily media call for Tuesday, April 21st. Governor Walz is not able to join us for today's call, but our speaker lineup will include Minnesota Commissioner of Health Jan Malcolm, followed by Infectious Disease Division Director Chris Erzman. We also have Health Regulation Division Director Michelle Larson on the line to provide more details about how the state works with long-term care facilities to prevent COVID-19 infections and to deal with cases when they do happen. Following the opening comments from Commissioner Malcolm and Directors Erzman and Larson, we will open it up for questions from reporters. With that, I will turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. Just to start, as usual, with the quick situation update globally and nationally first. As of early this morning, the global total of cases was nearly 2.5 million and 171,000 deaths. In the United States, we were rapidly approaching 788,000 cases and 42,364 deaths. In Minnesota, we are at a new lab-confirmed total of 2,567 cases, an increase of 97 from yesterday. So these last number of days, we've been on kind of a similar pace of daily increases. We had also 18 deaths reported since yesterday, but we also learned that one of the deaths had been reported in error. So our net increase was actually 17, bringing us to a new total of 160 deaths in Minnesota, which we are every day sorry to learn and think about the loss of those loved ones. This new set of 18 deaths includes 16 in Hennepin County, 1 each in Ramsey and Washington. Again, 14 of these 18 deaths occurred in residents of long-term care facilities, which is, again, part of the reason that we're going to give some additional focus to that topic today. The total includes 3 people in their 90s, 9 people in their 80s, 2 in their 70s, and 4 in their 60s. As of today, 1,254 patients have been released from isolation. There are currently 237 patients hospitalized, 117 of those in intensive care. There was no net increase in hospitalizations yesterday, so it appears that for the most part there were folks moving from intensive care into regular medical surgical beds. I think with that, perhaps I'll just remind that we do have a large number of long-term care facilities in the state with at least one case, whether that is a healthcare worker or a resident. And as Chris, I'm sure, will detail, we've been closely tracking the situations in these facilities and surrounding a facility with even one case with some additional attention and resources. So I will, I think at this point, pass it off to Chris Erzman, and then Chris will pass it to Michelle Larson. Thank you.
Thank you, Commissioner. As you're aware, and as we've talked about on prior briefings, we know that residents of congregate care settings, or those in assisted living, nursing homes, group homes, are at very high risk of severe disease due to COVID-19 because of their older age and medical conditions. And so because of that, when we're made aware of the potential for COVID-19 to be introduced into one of these settings, we take very rapid action. But even before we had cases identified in congregate care settings, we had been proactively working with leadership in these facilities. So since March 4th of this year, we have been having weekly calls with long-term care facilities and provider organizations to relay up-to-date information about recommendations, what's going on with the outbreak, any changes in guidance from the Department of Health or CDC, including guidance from our Health Regulation Division. And so we have a call today, this afternoon, and I can tell you that our most recent call was attended by almost 1,500 participants. So these are sought-out calls. When we're notified about a confirmed case of COVID-19 in a congregate care setting, we initiate a comprehensive investigation. We start by having a call with administrators and clinical staff of the facility, as well as representatives from the Department of Health from our surveillance, infection prevention, healthcare worker exposure work groups, et cetera. And so initially, our goal is to do an extensive case interview to learn more about the case and who their contacts may have been, so that we can identify potentially exposed residents, staff, and healthcare personnel. And we have developed guidelines for these resident healthcare personnel and staff contact tracing, as well as guidelines for assessing the type of exposure that someone may have had, all based on guidance from CDC. And based on these investigations and interviews, we will make recommendations for isolation, quarantine, and or work exclusion. So this is all part of the initial assessment. One of the other things that we do with the facility is we go over infection prevention and outbreak control measures. And this includes things like isolating ill residents, or if it's not possible to isolate a resident in a private room, to make sure that we are cohorting ill residents together. We also make recommendations for quarantine of exposed residents, so that residents who may have been exposed to a case are also kept separate for 14 days in case they would develop symptoms. We go over the type of precautions that the facility should use when caring for these patients, these residents, universal precautions, droplet precautions, and we also talk about the type of personal protective equipment that should be worn when caring for ill residents. We recommend universal masking for source control, and you've heard us talk about this even in the non-healthcare setting, that we all can wear masks when we're out and about as a means of source control. That is, limiting the opportunity for the wearer to share droplets with the people around them. So we do recommend that also in the long-term care setting. We make sure that visitor restrictions are in place and that group activities have been canceled. And this has taken place in just about all facilities, but we have, we check on this because we have identified some, that may have missed that recommendation. And then we also provide guidance on disinfection and cleaning. And it's a lot of information to convey, and so we have a team of infection preventionists or infection control specialists who are available and can do a virtual assessment of the facility and walk through the facility with them and work with them on specific steps that they can take to make their facility as safe as possible. We also provide tools on monitoring of healthcare workers, making sure that they're assessing both their healthcare workers as well as their residents for potential symptoms of COVID-19. An important part of what the facility does in terms of having a first case of COVID is making sure that they're communicating with residents, their families, and staff, and so we provide them with a letter and talking points that can be used. And we want to be sure that facilities have the type of close and ongoing support that they need. So each facility that has an outbreak is assigned to a nurse case manager. And the nurse case manager works with them daily in identifying ongoing issues. If they have questions or concerns about infection control, personal protective equipment, staffing issues, any of those things, the case manager is the link back to the multiple teams that we have, the healthcare worker team, the infection control team, the EPI team, as well as they serve as a link to our State Emergency Operations Center, which Michelle is going to be talking about. So they end up being the boots on the ground for the facility so that they have a single point of contact within the agency and can be easily connected to whatever resources that they need. More recently, we are helping facilities, in addition to dealing with a case in a resident, staff member, a contracted staffer, we're also helping facilities address the safe transfer of patients with COVID-19 to their facility. So there are situations in which an acute care setting needs to transfer someone who has had COVID-19 into a long-term care situation, or there's been a need to transfer between facilities. And so we have some facilities where there has not been a case, but they have the space and the staffing and PPE that's needed to be able to accept a resident. And so our nurse case managers are also assigned to these facilities to help them navigate that transfer. The goal is to ensure that these facilities have the tools and resources that they need so that they can safely care for these new residents. That gives you an overview of the kinds of things that we're doing on the outbreak response side. But what we found is that we need more resources and we need to do more forward thinking. And so I'll turn it over to Director Michelle Larson to talk to you more about that type of work.
Hi, everyone. Thanks, Chris. This is Michelle Larson. I'm the Health Regulation Director at the department. And going off of what Chris said, we really look at it once we get to past this point of that initial response as a two-pronged planning approach. So there's this current response that Chris just talked through, and I'll extend off of that. And then we have more of a long-term planning that we're trying to do as well. So the Minnesota Department of Health is also part of the State Emergency Operations Center. And I'm the lead for the long-term care work within the SEOC, which is an acronym for that I'll continue to use. So as the case manager and the EPI team continue to be the conduit back and forth to the facility, they will reach out if something is starting to brew. If it's getting to be a bigger issue than maybe what the facility can handle. And that can happen pretty quickly. They are often working with local resources or maybe the emergency manager or local public health. But if things start getting worse, for an example, if there's a major staffing problem at the facility where staff are becoming ill, they might call out and ask, what can we do for staffing for this particular facility in this particular area? So the SEOC may be called to help plug in the right connections to help them with their particular resources. The SEOC role is not there to fix everything for the facility along the way for every part, but to be a conduit back to resources that could possibly help. A lot of the times, obviously, state or local government agencies may be able to help with this, depending on what it is. Currently, in order to help with immediate response where we see a facility really starting to be overwhelmed, the SEOC is building out a crisis team model. So we're starting to do that now, like where Chris said that they're calling back in for help, and we're building out a more formal model of this, made up of local and state staff. So once we get that notification by a case manager and that EPI team, a crisis response team could be out there for only about 3 or 4 days, just to be on site to help the facility administrator and local partners identify areas that could assist. It's important to understand that there's a lot of different types of long-term care facilities around the state, and depending on what their outbreak is at that time, they may be having different needs. So not one size fits all for this scenario. So to really get a team out there and help them immediately is helpful to them. Another immediate help for long-term care facilities that we are putting together in SEOC is an information line just for long-term care. That's different than the MDH hotline provider line. This is a type of phone line that's tied to 911 and 411 for these long-term care facilities so that they can get help with a specific need if they just have a question or they can't get a hold of somebody that they need to get a hold of, because we really want to round out as much response for them that we can at all hours of the day, all the time. So that's those immediate current response work that's going on. For long-term planning, as this continues to go on, and we think about how we're going to sustain this from the state resource side and continuing to help our local partners, it's our goal to get in front of these vulnerable facilities proactively so that we have a better idea of who can help, where, with fast-moving outbreaks in long-term care facilities. We are continually refining our processes and communications and every aspect of every work that we do to help these facilities and to better understand what the needs are of these facilities and what is available in their communities. For instance, we have a part of the department that regulates these long-term care facilities. So we really want to go back in and look at where are facilities that just have infection control problems on a non-COVID day. What facilities haven't been surveyed in a long time, and really go back and proactively contact them and get out there and try to help them before they have an issue that gets out of hand and they really have a crisis overnight. Mike, that's about it. I can turn it back over to you if there's questions.
Great, thank you. Operator, I think we're ready to take questions.
At this time, as a reminder to ask a question, please press star followed by the number 1 on your telephone keypad.
We've been listening to an update on the coronavirus situation from the Minnesota Department of Health, specifically focused on those long-term care facilities today. We'll continue to track developments and bring you updates on our website and mobile app and on WDIO News at 5. See you then.
This has been a WDIO News special report.